So thank you very much for the introduction and thank you for the opportunity to speak. I'm going to talk today about restarting anticoagulation after a bleed, and unlike Dr. Capo's presentation, which was both extremely good and also extremely evidence-based, my talk is a little bit less evidence-based only because most of the stuff that I'm going to talk about has not been subject to high-quality research. So in terms of conflict of interest disclosures, I do have a number of them that are relevant to this talk. For example, I have received funding for various projects from AstraZeneca, which currently has the ownership of Andexanet Alpha in most countries in the world, as well as from other companies. The ones highlighted in red in this slide are those that I think are a relevant conflict of interest. I also serve on an advisory capacity with two companies that make reagents involved in anticoagulation monitoring, and I have worked for a large number of other agencies in various capacities, including the American Society of Hematology, and I hold an endowed chair at McMaster University, which was funded by Leo Pharma, although Leo has nothing to do with how I use the money. So I'm going to talk about all patients who are admitted with bleeding should have a plan for re-anticoagulation outlined in their chart at or shortly after their admission. And failure to re-anticoagulant patients is a common cause of medical error as it's associated with increased morbidity and death. And I'll show you evidence for that through the course of my presentation today, that we should be really attentive to making sure that all patients who come into the hospital with a bleed are considered for restart of their anticoagulation in order to avoid avoidable thrombotic complications. So every patient should have a plan, and the plan should consider why is the patient on anticoagulation and what is the risk of thromboembolism without it? What is the impact of the bleed and what is the rebleed risk if anticoagulation is restarted? Are there modifiable risk factors for bleeding? And if we restart, how long should we wait before restarting? What agents should we choose? And does the patient need multiple agents restarted if they came into the hospital on multiple agents? I'll present a little bit of information here about some of the reversal agents we have available to us, but I'm not going to focus on that. I'm going to focus much more on the data that comes from those studies that look at the risk of thrombotic complications. So this is one of the classic papers in the field. It was published now a number of years ago in the New England Journal, and it examined the utility of idarucizumab for dabigatran reversal. I think we're all familiar with this paper, and I'm not going to concentrate on how effective idarucizumab is. I'm going to concentrate on the thrombotic complications. In this study, there were 51 patients who were actively bleeding at the time of hospital admission. And when you look at those patients, if we look at thrombotic events that occurred beyond 72 hours after they received the idarucizumab, that occurred in 4 of the 51 patients, and that was measured out until 30 days. And if you took 51 randomly selected patients who were admitted to the hospital who received appropriate DVT prophylaxis, you would never expect to see 4 of them to have a clot, which suggests that these patients who came into the hospital taking dabigatran for the management of idarucizumab associated, of dabigatran associated bleeding, all had a hypercoagulable state to a greater or lesser extent, and that hypercoagulable state was probably what caused their original event, their deep vein thrombosis, their pulmonary embolism, their MI, or their CVA. And so when you stop their anticoagulants, you can expect them to suffer a rate of thromboembolism. The rate of thromboembolism seen in these patients is far in excess of those that would be expected in a background rate of population. It reflects the fact that patients receiving anticoagulants are predisposed to thrombosis. I think we all know that. And then if we look at the similar data for andexanet alpha, which is the reversal agent for the 10A inhibitors, again, not focusing on the efficacy of the drug, but rather focusing on its impact on thrombotic events. We're probably all familiar with this study, which was published by Stuart Connolly, now again a number of years ago in the New England Journal, a prospective single-arm study of andexanet for the treatment of 10A inhibitor-associated bleeding. The study enrolled 352 patients who were thought to have received a 10A inhibitor, apixaban, rivaroxaban, or others within 18 hours of their presentation. They were followed for a minimum of 30 days. And interestingly enough, here the rate of thromboembolic events was much higher. In fact, of the 352 patients, 34 patients suffered of thrombotic events, and of these, 2/3 were beyond 6 days after the event and included MIs, strokes, deep vein thrombosis, and pulmonary embolism. Of the thrombotic events, The majority, 26, occurred prior to the restarting of any anticoagulants. So delay in restarting anticoagulants was a very strong predictor of thrombotic events. And 34 occurred prior to the restarting of therapeutic dose anticoagulants. That means that when patients came into the hospital with a bleed, they were treated with andexanet alpha. Many of them received prophylactic doses of anticoagulants, but they weren't started back on their therapeutic doses, which they were on prior to their admission. And in fact, failure to restart oral anticoagulants was a very strong predictor of subsequent development of thrombosis, insofar as once therapeutic doses of anticoagulants were restarted, there were no cases of thrombotic events. So the conclusion from both of these studies is that the risk of thrombosis is higher after bleeding, and restarting anticoagulants may mitigate this risk. If we presume that when a person comes in with a bleed, excuse me, and their anticoagulants are stopped, that we need to restart, then we need to understand when we should restart. And unfortunately, there's been very little research carried out into the field of trying to determine when anticoagulants should be restarted. In fact, optimal timing may never be known because this, excuse me, doing studies in this field are very difficult. And what we want to do when we restart anticoagulants, oh, I have to excuse myself for a second and get a drink. I'll be back in 1 second. I apologize.
It's okay. Okay, no.
I apologize. So optimal timing of restarting may never be known because it's really difficult to do randomized control trials in this setting. But this paper suggested that 7 to 14 days may be optimal for these patients. 7 to 14 days probably minimizes the risk of recurrent bleeding, and it doesn't appear to increase the risk of thromboembolism and death. But in fact, when you're trying to make these decisions, the most important decision point to use is to look at the severity of the underlying bleeding event, the success of the interventions for bleeding, and the underlying thrombotic risk. So let's look at each of these in turn. A patient who has an episode of epistaxis, which is clinically concerning but unlikely to be medically significant, will have a very different implication for restarting anticoagulants than if the patient had an upper or lower GI bleed or an intracranial hemorrhage. Let's look at the success of any interventions. If the patient comes in with a lesion that is easily rectifiable, for example, they have a duodenal ulcer, which is fulgurated, and they receive appropriate acid suppression, and they have an endoscopy performed which shows that the lesion has largely resolved by 2 weeks. That gives you a very different risk of rebleeding than if the patient has angiodysplasia and a lesion that cannot be successfully treated. And then finally, the underlying risk for thromboembolism should be considered, and I'll go through this in more detail later. But suffice it to say that selected patients can be identified who have a high risk of thromboembolism, and other patients may have a very low risk, and we'll talk a little bit more about that later. These decisions should be made for every single patient who comes into the hospital with a bleeding complication. A variety of different consensus guidelines have been put together which help us to understand when patients should be restarted. And although these are not truly evidence-based, they do bring together a group of experts as well as best evidence to make recommendations about how specific therapies should be used in specific patients. I won't go through this in any detail other than saying that we should look carefully at the characteristics of the patients, the characteristics of the bleeds, and the need for anticoagulants. And we'll talk more about that a little bit later. In some cases, it may not be reasonable to restart the anticoagulants. In fact, if the risk of rebleeding is sufficiently high, permanent discontinuation may be indicated. Otherwise, in many other cases, in fact, in the majority of cases, after the bleeding event has been effectively treated, it's completely reasonable to restart the anticoagulants. sometimes at different doses, but frequently at the same dose that the patient came in with. Again, as I mentioned at the start of the talk, a common error is to have the patient admitted, stop the anticoagulant, discharge the patient, forget to restart the anticoagulant, and the patient presents later on in life with a thrombotic event, which is otherwise avoidable. Anticoagulation follow-up plans should always consider why is the patient on anticoagulants and what is the risk of thromboembolism without it? What's the impact of the bleed and what is the rebleed risk if the anticoagulation is restarted? Are there modifiable risk factors for bleeding? And if we restart, how long should we wait before restarting? What agent should we choose? And does the patient need multiple agents restarted if they were on multiple agents at the time of admission? So let's look at each of these questions individually. So I'm going to go through this is the same slide I just showed, every one of these questions individually. Why is the patient on anticoagulation? What is the risk of thromboembolism without it? So if you have a patient who had an episode of venous thromboembolism 6 months ago, that is a very different clinical implication than a patient who had high-risk atrial fibrillation or a episode of venous thromboembolism just 2 weeks ago. And obviously, the underlying risk of first or recurrent thrombosis would dramatically influence our enthusiasm for restarting anticoagulants. The second question is, what was the impact of the bleed and what is the rebleed risk if anticoagulation is restarted? A bleed occurring after a motor vehicle accident is very different from a bleed occurring due to amyloid angiopathy of the brain or diffuse arteriovenous malformations. And I'll run through some examples of this in a few minutes. It's really important, therefore, to understand why the bleed occurred. It's not enough to identify that the patient had a bleed. It's important to see why the bleed occurred. So, for example, I'm on service right now. We have a patient in the hospital who is having a GI bleed. They're going for a colonoscopy on Tuesday, and at that point, we'll decide what the cause of the patient's bleed is. If it's an arteriovenous malformation, we'll have a very different approach to restarting anticoagulants than if it's due to something that's rectifiable, for example, a colonic ulcer. Next question is, are there modifiable risk factors for bleeding and have they been addressed? A bleed occurring after a treatable risk factor or a patient who was on unneeded antiplatelet therapy has a much lower risk of recurrence than a bleed in a patient with a non-remediable lesion. And just to reiterate, a common contributor to bleeding is unneeded compound antiplatelet therapy. We actually have really good evidence nowadays to help us understand which patients should be on double versus triple therapy for the prevention of arterial thrombosis. And if there's a decision to restart the anticoagulants, how long should we wait? As mentioned with respect to that paper that I just presented, this is largely unknown. However, in general, physician preferences are to wait too long. The natural error that physicians make is our errors of omission rather than commission. That means rather than start something earlier than we're predisposed to and potentially making a bleed occur, which we feel guilty about, we prefer to just not restart the anticoagulants and leave them off for too long. The patient then has a thrombotic event. But because we didn't do anything active, we don't feel that we had responsibility for it. However, the decision about when to restart needs to be driven by the characteristics of the bleed, the nature of the anticoagulant that's being used, and physician and patient preference. And physician and patient preference are, of course, critically important in these discussions because patients may not wish to suffer recurrent bleeds, or more importantly, patients may be willing to tolerate significant numbers of bleeds in order to avoid a thrombotic event such as a stroke. And then the question comes down to what agent should we use? And this really depends on the clinical circumstance. And it's really important to realize that the drug that the patient came into the hospital with may not be the drug that the patient goes home on. And there are times at which you would switch those based on the patient's risk characteristics. So, for example, a patient on long-term medication that slows the metabolism of DOACs, warfarin may actually be a preferred medication. And that's because you can monitor warfarin and adjust the dose. So, for example, a drug which interacts with the clearance of apixaban or rivaroxaban may actually be required over the long run, and it may then be easier and safer to use a drug which can be monitored. A patient on warfarin with a spontaneous intracranial hemorrhage that occurred and was felt to be at low to moderate risk of recurrence. We know that warfarin is associated with a higher risk of intracranial hemorrhage than is a DOAC. A DOAC may actually be preferred, and that occurs in many settings where a patient presents with an intracranial hemorrhage receiving warfarin, and after due consideration and evaluation for the cause, it's actually decided the patient should be sent home on a direct oral anticoagulant because it's presumed to have a lower risk of thrombosis. And then finally, always remember mechanical causes of bleeding. So a patient with end-stage renal disease with a major bleed due to fistula cannulation who's receiving an anticoagulant, it may not be anything at all to do with the anticoagulation. It may be more careful attention to better technique for the cannulation rather than a change in therapy. Always remember the potential that mechanical causes can cause bleeding and that correcting those mechanical causes. We see this a lot now in our ECMO program where there's a lot of device related bleeding. It's not due to anticoagulation, it's due to the devices. And perhaps by improving our device management techniques, we might be able to reduce our risk of bleeding. This is an older paper published in 2004, but I bring it to your attention just to show how frequently patients are on combined medications. So this is a retrospective cohort of a national database in the United States, which enrolled 10,000 patients who were being treated with warfarin. And these patients had a mean age of 77, and fully 20% or 20% or 19.4% were on an antiplatelet drug. Very high use rates of coincident use of two drugs that can cause bleeding. Antiplatelet use was less common among women, older people, persons with cancer, terminal diagnoses, dementia, and bleeding history, and patients logically with coronary artery disease were more likely to receive an antiplatelet therapy. It's important to note that in multivariable analysis, factors associated with the first bleeding event were age, so older age, anemia, but importantly, a history of bleeding, which is the strongest predictor of a recurrent bleed, and concurrent antiplatelet therapy. So if a patient's on dual therapy, it's going to increase the risk of bleeding. Every time a patient's on dual or triple therapy, you should consider whether they need to be on that therapy as a way of reducing the risk of bleeding. And this is a very nice paper published by a colleague of ours, Renato Lopes, who it's called the Augusta study. It was published in the New England Journal now 3 years ago. And what Renato and his friends did is that they identified the fact that in patients with acute coronary syndromes, coincident antithrombotic medications were frequently prescribed, and triple therapy was frequently used in a person with new ischemic cardiac disease coupled with atrial fibrillations. This study tried to examine whether or not there were better strategies than triple therapy for preventing recurrent ischemic events, and it came to the conclusion in that using a factorial design, a large multicenter clinical trial, that in patients with atrial fibrillation and recent acute coronary syndrome or PCI treated with a clopidogrel-like drug, an antithrombotic regimen that included apixaban without aspirin resulted in less bleeding and fewer hospitalization without a significant difference in the incidence of ischemic events when compared with regimens that included vitamin K antagonists, aspirin, or both. And so this study essentially drove the final nail into the coffin of triple therapy for patients who have atrial fibrillation and a new coronary event. It's very clear from this study that if you're tempted to use a combination of aspirin plus a P2Y12 inhibitor, such as clopidogrel, and an antithrombotic, the preferred group of agents that's associated with identical risks of thrombosis and reduced risk of bleeding is actually not dual antiplatelets. It's a single antiplatelet that is this P2Y12 inhibitor and apixaban used at usual doses. The combination of apixaban plus a P2Y12 inhibitor was equally as effective and safer than triple therapy. So I'm going to now present in the last few minutes a number of different cases and look carefully at each of these questions that I've identified. So the first case is Mr. RT. He's a 72-year-old gentleman with atrial fibrillation taking apixaban to prevent stroke. He receives 5 milligrams orally twice daily, and about 6 hours after taking a dose is struck by a car while crossing the road, resulting in multiple fractures and a large retroperitoneal hemorrhage. He's admitted to the hospital to the intensive care unit for critical care. He receives VTE prophylaxis with low molecular heparin, and 1 week later is transitioned to a rehab facility with stable blood work. When can his anticoagulants be safely restarted? So let's look at each of these questions I defined earlier in the talk. Why is the patient on anticoagulation, and what is the risk of thromboembolism without it? This person has atrial fibrillation with a high risk of stroke, obviously something we want to avoid having happen. What was the impact of the bleed, and what is the rebleed risk if anticoagulation is restarted? The bleed was significant. It was a retroperitoneal hemorrhage, which can be fatal, but it was secondary to an injury. So we think the risk of recurrence is going to be really low. Are there modifiable risk factors for bleeding? These are not relevant. This person had a car accident or was hit by a car. There's nothing we can really do to prevent that from happening except to ask him to be more careful crossing the road. If we restart, how long should we wait? Well, 1 week, he's now a week after his accident, is probably adequate. There's no reason for him to rebleed this late. And you might want to extend that a little bit, but personally, I'd be prone to restart it fairly quickly given his high risk of suffering a stroke. What agent should we choose? I think it's very reasonable for him to go back on his apixaban. And does the patient need multiple agents restarted if they were on multiple agents? They weren't on multiple agents when they came in, so this is not a relevant question. Let's look at a second patient here. Miss LF is a 62-year-old woman on warfarin for long-term secondary prevention of VTE. She suffered a deep vein thrombosis and pulmonary embolism 7 years ago after a short haul flight. And it's been decided to leave her on anticoagulation because the physicians felt that wasn't a strong enough risk factor for a venous thromboembolism. Unfortunately, she presents with a lower GI bleed, which is proven to be due to multiple arterial venous malformations. So we go back to our questions. Why is the patient on anticoagulation, and what is the risk of thromboembolism without it? Secondary prevention of VTE is the indication, and this person really has a low risk and low consequences if the VTE recurs. We're comfortable leaving this patient off anticoagulants. What is the impact of the bleed, and what is the rebleed risk if anticoagulation is restarted? This was a very minor bleed, to be quite honest. Lower GI bleed, she was quite stable through it, but rebleeding is almost certain because we did nothing to address the arterial venous malformations. Are there any modifiable risk factors for bleeding? No, multiple arterial venous malformations are not treatable. You might be able to treat one or two, but most patients have hundreds or thousands. And if we decide to restart, what medications? In fact, in this patient, we're going to make a decision not to restart. So we're willing to take a small risk of recurrent thrombosis in order to prevent an almost certain risk of recurrent hemorrhage. Case 3, this is a little bit of a more complicated case. A 29-year-old woman has started on HIV therapy after presenting with an initial diagnosis with new HIV. She's on rivaroxaban after a history of 2 prior episodes of venous thromboembolism, including a life-threatening PE which required mechanical therapy, that is, a surgical procedure to remove. She has evidence of pulmonary hypertension and presents with a small spontaneous intracranial hemorrhage. Now, this is obviously a very, very complicated case, but the question is, why is the patient on anticoagulation and what is the risk of thromboembolism without it? She's at very high risk of recurrence. She's had previous recurrent life-threatening venous thromboembolism, and she has pulmonary embolisms and pulmonary hypertension, so she's likely to die if she has a recurrence. What was the impact of the bleeding, and what is the rebleeding risk if anticoagulation is restarted? This bleed is in a very high risk area, but the risk of rebleeding is unknown. Are there modifiable risk factors? Um, no, but she is on nevirapine as one of her anti-HIV drugs, and that has an impact on rivaroxaban levels. It actually increases rivaroxaban levels. That's a predictable side effect. So perhaps this woman actually had a bleed because she was on a direct oral anticoagulant, and she was on a drug which interacts with this. This may actually be an iatrogenic complications. So then the question is, should we then maybe consider restarting but with a different agent? And the answer to that here is I think so. Restart is indicated because she has a very high risk of recurrent thrombosis, but I would wait for at least 14 days. What agent should we choose? I would actually choose warfarin in this case. So take a young woman and take her off a DOAC and put her on to warfarin because it can be monitored and therapy adjusted based on the interaction. Does the patient need multiple agents? Yes, she does. She needs her anti-HIV therapy and she needs an anticoagulant. So let's pick the best possible combination. The final case is Mr. PM, who's a 92-year-old male who presents with a small spontaneous ICH in an area suspicious of amyloid angiopathy. Amyloid angiopathy is a high risk for rebleeding. He has high risk atrial fibrillation and is receiving low dose apixaban. Why is the patient on anticoagulation? So he has a high risk of atrial fibrillation associated thrombosis, including stroke, and he has a very high risk of bleeding. What was the impact of the bleed, and what is the rebleed risk if anticoagulation is restarted? He has a very high risk of death and long-term morbidity if the anticoagulants are restarted, but he also has a high risk of morbidity if they aren't because of the risk of stroke. So the risk of thrombosis and bleeding is high. Are there modifiable risk factors for bleeding? The answer to that question is no. And if we restart, what will happen? Well, despite the fact this gentleman has a high risk of stroke, we decide not to restart because of our perception that he has a very high risk of suffering bleeding, which we cause through anticoagulants. So in summary, all patients who bleed while receiving anticoagulants should have a plan to restart their anticoagulants spelled out shortly after they bleed. The plan might simply be to not restart, but this should be specified. The large majority of patients can restart some form of therapy. A change of dose or agent may be required, and polypharmacy such as dual or triple antiplatelet therapy should be carefully reviewed and mitigated where interested.